My name is Dr. Lisa Park, and I'm a cardiac anesthesiologist at Stanford Medical Center in California. I've been administering anesthesia for 17 years, specializing in open heart surgery, valve replacements, bypass procedures, the most complex, high-risk operations where keeping patients safely unconscious while their hearts are stopped is the difference between life and death. I've put over 5,000 patients under anesthesia. I know the pharmacology, the monitoring systems, the precise balance between too little sedation and dangerous overdose. I can read anesthesia depth meters, brain wave patterns, vital signs. I understand consciousness and how to suppress it. But on September 14th, 2023, during a routine coronary bypass surgery, I saw something no monitor detected. The patient's eyes opened. He looked directly at me. His chest was open. His heart stopped, connected to a bypass machine. And he was awake, fully conscious, watching his own surgery for exactly 10 seconds. Then his eyes closed again. The monitors showed no change. Anesthesia depth remained stable. Brain activity unchanged. According to every objective measure, he'd never regained consciousness. But I'd seen his eyes. I'd watched him look at his open chest, at the surgical team, at me. I'd seen awareness, confusion, terror. And then it happened again and again. Different patients, different surgeries, always 10 seconds, always undetected by monitoring equipment. I was seeing consciousness windows that medical technology couldn't capture. Moments when patients woke during surgery, observed their own operations, then slipped back under, with no memory, no trace, no evidence except what I witnessed. Stanford Medical Center is one of the premier cardiac surgery programs in the world. Our operating rooms have the most advanced monitoring systems available: EEG-based anesthesia depth meters, continuous vital sign tracking, real-time brain activity analysis. We pride ourselves on safety, on preventing awareness during anesthesia. Anesthesia awareness, patients waking up during surgery, is every anesthesiologist's nightmare. It's rare, maybe 1 in 1,000 cases, and when it happens, it's traumatic. Patients remember pain, paralysis, terror. It's a catastrophic failure of anesthesia management. Our monitoring systems are designed to prevent this. They track brain waves, detect consciousness before patients become aware. If someone starts waking up, alarms sound. I adjust medications immediately. But what I was seeing didn't trigger any alarms. I grew up in San Jose, California, daughter of Korean immigrants who owned a dry cleaning business. I was the first in my family to attend college, went to UC Berkeley for undergraduate, then medical school at UCSF. I completed my anesthesiology residency at Stanford and never left. 17 years later, I'm one of the senior cardiac anesthesiologists, supervising residents, handling the most complex cases. Cardiac anesthesia is demanding, precise work. During open heart surgery, the patient's heart is stopped. They're connected to a bypass machine that does the work of the heart and lungs. I'm managing their consciousness, their pain sensation, their vital functions, while surgeons operate on the most critical organ in the body. One mistake, too light anesthesia, too deep, wrong medication timing, and patients die or wake up on the operating table in agony. I've always been careful, meticulous. My awareness rate is 0. In 17 years, not a single patient has reported consciousness during my anesthesia. Until September 14th, when I started seeing what the monitors couldn't detect. September 14th, 2023, was a Thursday. I was scheduled for a full day in the cardiac or 2 bypasses and a valve replacement. The first case was Richard Foster, 61 years old, triple bypass for severe coronary artery disease. Standard procedure. I'd done hundreds of these. Richard was brought to or 5 at 7:30 a.m. I ran through my pre-op protocol, reviewed his medications, allergies, cardiac function. Everything looked routine. I explained the anesthesia process, reassured him he'd be completely unconscious, feel nothing. "Will I dream?" he asked as I started the formations. "Most patients don't remember anything," I said. You'll close your eyes here, and the next thing you know, you'll wake up in recovery. I administered the induction medications, propofol, fentanyl, rocuronium for paralysis. Richard's eyes fluttered closed. His breathing stopped as the paralytic took effect. I intubated him, connected the ventilator. My monitor showed appropriate anesthesia depth. BIS monitor reading 42, indicating deep unconsciousness. Perfect. Dr. James Chun, the cardiac surgeon, began at 8:15 a.m. Sternotomy, opening the chest. I watched my monitors continuously. Heart rate stable, blood pressure controlled, anesthesia depth appropriate, everything normal. At 9:47 a.m., Dr. Chen clamped the aorta and stopped Richard's heart. The bypass machine took over, pumping blood and oxygen through Richard's body while his heart lay still, ready for surgery. This is the most critical phase. The patient is essentially dead, heart stopped on mechanical support. I'm maintaining brain perfusion, preventing awareness, keeping every system stable while surgeons work. At 10:23 a.m., Richard's eyes opened. I was checking the bypass machine flows when I saw it. His eyes, both of them, opened wide. Not the fluttering of light, anesthesia. Not the random eye movement of REM sleep. Deliberate, conscious eye opening. He looked down at his chest, at the retractors holding his ribcage open, at his motionless heart visible in the surgical field. Then his eyes moved. Slowly, deliberately, he looked at Dr. Chen's hands working on his coronaries. Then at the bypass machine. Then at me. Our eyes met. I saw confusion, then recognition, then horror. His eyes were asking me, what's happening? Why am I awake? Why can I see this? I looked at my monitors. BIS reading, 41. Brain waves, deep anesthesia. Vital signs, unchanged. Every objective indicator said Richard Foster was completely unconscious. But his eyes were open. He was watching. He was aware. 10 seconds. That's how long his eyes stayed open. Then they closed again, slowly, as if he'd simply gone back to sleep. Everything okay, Dr. Park? Dr. Chen asked, noticing me staring at patient. Fine. Just checking the depth. Looked stable to me. It was stable. According to every measure, Richard had never woken up, but I'd seen his eyes. I'd watched consciousness return for 10 seconds while my monitors detected nothing. The surgery continued for another 90 minutes. Richard's eyes never opened. At 12:30 p.m., we closed his chest. At 1:15 p.m., I reversed the paralytic and allowed him to wake in the controlled, gradual way post-cardiac surgery patients should wake. Richard opened his eyes slowly, confused, groggy. Is it over? He mumbled through the breathing tube. Surgery went perfectly. I said, you did great. We removed the breathing tube an hour later. Richard was alert enough to talk. Did I dream? He asked. I don't remember anything. That's normal. Most patients don't remember. Did I wake up at all? During the surgery, my heart stopped. What makes you ask that? I don't know. Just a weird feeling. Like maybe I saw something, but I can't remember. You were completely unconscious the entire time, I said. The monitors confirmed it, and they had. Every monitor, every measurement, every objective indicator said Richard Foster never regained consciousness during his surgery. But I'd seen his eyes open. I'd watched him observe his own open-heart surgery for 10 seconds. I told myself it was a trick of the light, a muscle spasm, something explainable. Eyes can open without consciousness. It's rare but possible. Except his eyes had moved, deliberately, tracking the surgical field, looking at me with awareness. On September 18th, 4 days later, it happened again. Patient, Maria Santos, 54, mitral valve replacement. Severe valve disease requiring her damaged valve to be removed and replaced with a prosthetic. Standard cardiac procedure. Maria was pleasant, nervous, asking the same questions all patients ask. Will I feel anything? Will I wake up? Will I remember? You'll be completely unconscious, I assured her. I'll be monitoring you the entire time. Surgery began at 8:45 a.m. Everything proceeded normally at 10:37 a.m. with her heart stopped and Dr. Rachel Kim removing the damaged valve. Maria's eyes open. Not fluttering, not half open, wide open, alert, conscious. She looked at the surgical field, her chest open, her heart exposed, and still. Her eyes widened. I saw panic flash across her face, even though she couldn't move, couldn't breathe on her own, couldn't scream. Then her eyes found mine. She was pleading with me. Help me. Why am I awake? Make it stop. I grabbed my medication syringes, prepared to push more propofol, more sedation. But my monitors showed no change. BIS reading, 38. Deep anesthesia. Brain waves, suppressed. She wasn't waking up according to any measurement. 10 seconds. Her eyes closed. She was under again. I pushed extra propofol. Anyway, I increased my anesthetic gases. I deepened her sedation beyond what the protocols required. BP's dropping, the perfusionist noted. You okay over there, Lisa? Fine. Just being cautious. She's pretty deep already. I know, but I'd seen her eyes. I'd watched her wake up during the most vulnerable moment of surgery. Her heart stopped, her chest open, her life sustained by machines. And I couldn't let it happen again. The surgery concluded without further incidents. Maria woke up normally in recovery. How do you feel? I asked her. Tired. Sore. Did everything go okay? Perfect. Do you remember anything from the surgery? No. Should I? No. That's good. Most patients don't remember anything. But she'd been awake for 10 seconds. She'd seen her own heart surgery. And now she had no memory of it. Was that better or worse? To experience something so traumatic but not remember it, did the experience still matter if the brain didn't store the memory? Over the next 3 weeks, I saw 14 consciousness windows. 14 patients whose eyes opened during cardiac surgery. Always for exactly 10 seconds. Always undetected by my monitoring equipment. Always followed by no memory of the event. I started documenting patient name, procedure, exact time of consciousness window, what they observed. I noted my monitor readings at the moment their eyes opened. Always showing appropriate anesthesia depth. Always indicating they should be completely unconscious. The pattern was undeniable. I was seeing moments of awareness that medical technology couldn't detect. Brief windows when patients woke during surgery, observed their operations, then returned to unconsciousness before monitors registered any change. On October 6th, a case forced me to make a decision I couldn't take back. The patient was David Chun, 38 years old, emergency coronary bypass. He'd had a massive heart attack at his office, was rushed to Stanford, needed immediate surgery to restore blood flow to his dying heart muscle. Emergency cardiac cases are always more complicated. Patients aren't optimally prepared. The surgery is rushed. Risks are higher. I have less time to establish stable anesthesia, less margin for error. David was in OR3 by 2:15 p.m. I induced anesthesia rapidly, got him intubated, and on bypass as quickly as possible. Dr. Chun worked fast. David's heart was dying. Every minute mattered. At 3:47 p.m., with David's heart stopped and Dr. Chun grafting new vessels, David's eyes opened. He looked confused, disoriented. His eyes moved slowly, taking in the surgical field, the team. Then his lips moved. He was trying to speak around the breathing tube. I leaned closer. His lips formed words, silently. I feel it. He was feeling pain. Not just aware, in pain, during open heart surgery. While his heart was stopped. While every monitor said he was deeply unconscious. His eyes found mine. Please. It hurts. I pushed propofol. I increased fentanyl. I maxed out my anesthetic gases. I gave him every medication I could to deepen his anesthesia beyond any reasonable level. Lisa, his blood pressure's tanking, the perfusionist said. You need to back off. No, his BP is 65/40. That's too low. I don't care. Increase the bypass flows. Support his pressure mechanically. I'm not reducing anesthesia. Why? His depth monitor shows he's already too deep. Because he was awake. Because he was feeling pain. Because I couldn't let him suffer, even if no monitor in the world would prove he was conscious. 10 seconds passed. David's eyes closed. His lips stopped moving. I maintained the increased anesthesia for the rest of the surgery. David's blood pressure required mechanical support, vasopressors, extra fluids. Dr. Chen gave me concerned looks, but didn't question my management. David woke up normally in recovery. No memory of consciousness. No report of pain. According to every objective, I'd over-anesthetized him unnecessarily, caused hemodynamic instability for no reason. But I'd seen his lips. I feel it, and I'd made sure he wouldn't feel it again. On October 12th, I was called to a meeting with Dr. Andrew Morrison, the chief of anesthesiology. Lisa, we need to discuss your recent cases. You've been using significantly higher doses of anesthetics than protocols recommend. Several surgeons have noted hemodynamic instability that appears related to oversedation. I'm maintaining adequate anesthesia depth. You're exceeding it by a lot. Your BIS readings are consistently in the low 30s. That's deeper than necessary and increases risks. I'd rather err on the side of too deep than risk awareness. But your awareness rate is 0. It's always been 0. Why the sudden change in practice? I couldn't tell him. I couldn't explain that I was seeing consciousness windows that no monitor detected, that patients were waking up for 10 seconds, and my equipment showed nothing. I'm just being cautious. Cautious is good. Excessive is dangerous. I need you to return to standard protocols. What if standard protocols aren't enough for what? You have no awareness events. Your outcomes are excellent. There's no clinical reason for these changes. There are reasons I can't explain. Dr. Morrison's expression shifted to concern. Are you feeling all right? Is something going on that's affecting your judgment? I'm seeing things during surgery, things the monitors don't detect. What kind of things? Patients waking up for about 10 seconds, then going back on. And the monitors show what during these episodes? Nothing. Normal depth readings. Lisa, if the monitors show appropriate anesthesia depth, then the patients aren't waking up. That's what the monitors are. But I see their eyes open. I see them looking around. I see them in distress. Dr. Morrison was quiet for a long moment. I'm going to recommend you take some time off. And I'd like you to meet with Dr. Sandra Lee, one of our psychiatrists. What you're describing, seeing awareness that monitoring equipment doesn't detect, that's concerning. I'm not having hallucinations. These are real consciousness windows. Then explain to me how it's physiologically possible for patients to be conscious while their brain waves show deep anesthesia. Explain how they can be aware while BIS monitors, EEG, vital signs all indicate unconsciousness. I couldn't. I had no explanation. I only had what I'd witnessed 14 times in 3 weeks. I'll take some time off, I said quietly, but I'm not wrong about this. On October 15, I was placed on administrative leave pending psychiatric evaluation. Standard protocol when an anesthesiologist reports perceptual disturbances in the OR. I met with Dr. Sandra Lee 3 times over the next 2 weeks. I explained what I'd been seeing, the consciousness windows, the 10-second awakenings, the patient's eyes opening while monitors showed me. Do you believe these consciousness windows are real? She asked. Yes. Even though no monitoring equipment detects them, the equipment might be missing something. Maybe consciousness can exist in ways we don't know. Or maybe you're experiencing a form of hypervigilance, seeing awareness where none exists because you're anxious about anesthesia. I'm not anxious. I'm careful. There's a difference. 17 years without a single awareness event, and suddenly you're seeing them multiple times per week. That's a significant change. Something must have triggered it. What triggered it is that I started seeing the truth, that our monitoring systems don't capture everything, that patients wake up during surgery. We don't know it. Dr. Lee's assessment, possible delusional disorder with specific focus on anesthesia awareness. Recommend extended leave and ongoing psychiatric before return to clinical practice. I was diagnosed as delusional. My observations dismissed as psychiatric symptoms. On November 3rd, I received a letter from Stanford Medical Center. I could return to work only if I agreed to several conditions. Continue psychiatric treatment, accept oversight of my anesthesia management by a senior colleague, and administer anesthesia according to standard protocols without deviation. I couldn't agree to that last condition because I knew what would happen. Patients would wake up during surgery, experience 10 seconds of awareness and I wouldn't be able to do anything about it because my monitoring equipment would show they were asleep. On November 8th, I resigned from Stanford Medical Center. During my notice period, I was not allowed to administer anesthesia. I observed other anesthesiologists watch their cases, saw their patients, and I saw the consciousness windows continue. Different anesthesiologists, different patients, but the same phenomenon. Eyes opening for 10 seconds. Awareness returning briefly, then disappearing again, undetected. On November 15th, I observed a case that broke me. The patient was Jake Morrison, 12 years old, born with a congenital heart defect that now required surgical correction. Complex procedure. His heart structure was abnormal, required careful reconstruction. Dr. Susan Park was the anesthesiologist. Experienced, skilled, good reputation. Jake's parents had requested the best, and they got her. I stood in the corner of or 7, officially there to observe, but really just trying to get through my last week. Surgery began at 9 a.m. Jake's small body looked impossibly fragile on the operating. His chest was opened by 9:45. His abnormal heart was stopped by 10:15. At 10:47 a.m., Jake's eyes opened. He looked confused, scared. A child waking up to find his chest open, his heart visible, surgeon's hands inside his body. Dr. Park's monitors showed deep anesthesia. BIS reading 35. Jake should have been completely unconscious, but his eyes were open, and I saw terror. His eyes moved, searching. He couldn't turn his head, couldn't move because of the paralytic medication. But his eyes scanned the room desperately. 10 seconds. His eyes closed. At 11:23 a.m., his eyes opened again. Second consciousness window. More panic this time. Recognition that this nightmare was real. 10 seconds. Closed. At 12:08 p.m. Third window. His eyes were pleading. Why is this happening? Why won't someone help me? At 1:34 p.m. Fourth window. His eyes looked resigned, defeated. A 12-year-old boy accepting that he was trapped in a nightmare no one else could see. At 2:41 p.m. Fifth window. His eyes found mine across the aisle. I was crying silently behind my surgical mask. He saw me. He knew I saw him. And he knew I couldn't do anything. The surgery concluded at 3:30 p.m. Jake was transferred to pediatric ICU. He recovered perfectly. No memory of the consciousness windows. No trauma symptoms. No indication anything unusual had happened. But I'd watched a child wake up 5 times during open heart surgery. I'd seen him experience terror, confusion, pain, and helplessness. And because I was on administrative leave, because I wasn't managing his anesthesia, I couldn't deepen his sedation. I could only watch. That night, I wrote a detailed report of everything I'd witnessed over the past 2 months. 23 consciousness windows across 18 patients, each lasting exactly 10 seconds, each undetected by monitoring equipment, each followed by no patient. I submitted the report to Dr. Morrison, to the hospital's quality committee, to the anesthesiology department. I provided dates, times, patient names, monitoring data. 2 days later, I received a response from the hospital's legal department. My report had been reviewed. Their conclusion: no evidence of anesthesia awareness events. Monitoring data does not support reported observations. Recommend continued psychiatric for Dr. Park. My last day at Stanford was November 22nd, 2023. 17 years of anesthesiology ended because I could see consciousness that monitoring systems couldn't detect. I spent December trying to understand what had happened to me. I researched consciousness, anesthesia mechanisms, monitoring technology limitations. I looked for explanations for any scientific framework that would explain seeing awareness that brainwave monitoring missed. I found some interesting research. Studies showing that current anesthesia depth monitors don't measure consciousness directly. They measure brain wave patterns that correlate with unconsciousness. But correlation isn't causation. What if consciousness could exist in states that our monitors don't recognize? Other studies showed that some patients report dreams or vague awareness during surgery, even when monitors indicate deep anesthesia, usually dismissed as postoperative confusion. But what if they were real memories of brief consciousness windows? In January 2024, I took a position at a small private surgical center in Palo Alto. Outpatient procedures only, colonoscopies, endoscopies, minor orthopedic surgeries. Nothing cardiac, nothing with patients' chests opened and hearts stopped. I use local and regional anesthesia whenever possible. When general anesthesia is necessary, I use deeper sedation than protocols require. I watch patients constantly. I haven't seen any consciousness windows in months. Maybe because the surgeries are less invasive. Maybe because I'm using more sedation. Maybe because whatever allowed me to see those windows at Stanford doesn't work here. Or maybe patients don't wake up during colonoscopies the way they do during cardiac surgery. On March 14th, 2024, I received an email from an address I didn't recognize. Subject line: I see them too. I opened it carefully. Dr. Park, my name is Dr. Jennifer. I'm a cardiac anesthesiologist at University of Washington Medical Center in Seattle. I read about your case through some colleagues. I need you to know you're not crazy. I see the consciousness windows too. During cardiac surgery, always 10 seconds, always undetected by monitors. I've seen it 37 times in the past year. I haven't told anyone because I saw what happened to you, but I need you to know you're not alone. They're real. The patients really do wake up, and no one believes us. I stared at that email for a long time. Someone else had seen what I'd seen. Someone else had watched patients wake during surgery while monitors showed deep anesthesia. Someone else knew the truth. I wrote back immediately. We talked on the phone for 2 hours. She described consciousness windows identical to what I'd witnessed, the same duration, the same lack of monitoring detection, the same patient amnesia after. Why do you think we see them when the monitors don't? I asked her. I don't know. Maybe we're more observant. Maybe we're looking for something the monitors aren't designed to detect. Or maybe consciousness during anesthesia is more common than we think, and most anesthesiologists just don't notice. Do you deepen sedation when you see a window? Every time. I give more medication than I should. I risk oversedation, but I can't let them be awake and not help them. Do you think they feel pain during those 10 seconds? I don't know. I hope not. But some of them look like they're in distress. Like David Chin looked at you. We started a private support group, just the two of us. 2 cardiac anesthesiologists who could see consciousness windows that medical technology couldn't detect. We shared our observations, compared notes, tried to understand what we were witnessing. I'm 44 years old. I've been an anesthesiologist for 17 years. I've safely managed anesthesia for over 5,000 patients. And I've seen 23 consciousness windows. Brief moments when patients woke during surgery, observed their own operations, then returned to unconsciousness with no memory of the experience. I lost my job at one of the best hospitals in the world because I reported what I saw. I was diagnosed with a psychiatric disorder because I observed something monitoring equipment couldn't confirm. But I know what I witnessed was real. I know patients wake up during cardiac surgery in ways our technology doesn't detect. I know that 10-second consciousness windows exist, and most anesthesiologists never notice them. And I know there's at least one other person who sees what I see. Maybe there are more of us. Maybe there are anesthesiologists all over the world who've noticed patients' eyes opening during surgery, who've seen awareness return for brief moments, who've wondered if the monitors are missing something. Maybe they stayed silent because they saw what happened to them. Maybe they're deepening sedation, quietly protecting patients from consciousness windows no one else acknowledges. Or maybe they're following standard protocols, trusting the monitors, believing that what the technology says is the whole truth. I can't work in cardiac anesthesia anymore. I can't watch open heart surgeries knowing that patients might wake up for 10 seconds and I won't be able to prove it to anyone. But I still see the windows. Even in my outpatient cases, even in minor procedures, I watch for that moment when eyes open unexpectedly, when awareness returns briefly before monitors register any change. And I wonder how many patients wake up during surgery without anyone noticing. How many consciousness windows exist in operating rooms every day, unseen by anesthesiologists who trust their monitors more than their own observations. How many 12-year-olds wake up 5 times during heart surgery, experiencing terror that no one will ever validate, that they won't even remember. I hope Dr. Wu and I aren't the only ones who see them. I hope there are others watching, noticing, protecting patients from awareness that monitoring systems miss. Because someone needs to see the consciousness windows. Someone needs to watch the patient's eyes, not just the monitors. Someone needs to know that the technology doesn't capture everything. And in this timeline, that someone is me.